Well, thanks everyone, and thank you kindly for asking me to speak today. I've been given a very, can everyone hear me? I've been given quite a large topic to talk about, overview of current clinical care and research, so it's a lot to cover in a fairly short space of time, and I hope that I've covered it in an adequate depth so that you come out of it with some new knowledge and perhaps consolidation of things that you already know. It takes us neuro-oncologists perhaps years or decades to learn all this stuff. So let's give it a go. So brain tumors, now I'm supposed to cover all of brain tumors, and there are a wide range of brain tumors. I think there are about 49 in total, and I can't possibly speak about each and every one of them. Obviously, some are more common than others. There are benign tumors, there are primary brain tumors that fall into a low-grade variety as well as a malignant variety, and then we have secondary brain tumors as well. So it's a wide range. There's no homogeneous group, and every patient needs to be treated specifically, and we need to embark on a customized treatment plan for each patient. I'd like to start off mainly with this slide, and this slide kind of illustrates why management, clinical care of brain cancer as well as research is challenging and feels a bit disjointed. And that's largely because we make up a very tiny percentage of the overall cancer diagnoses in the country. So brain cancer accounts for 1.4% of all cancers in the world. The big cancers are obviously breast, prostate, melanoma, bowel, and a few others. And therefore, in terms of clinical care as well as research, the focus of governments and major organizations is all about these big cancers. That leaves us out. However, I see that as a little bit of an advantage for us sitting here, because it's up to us. It's up to all of us here in this room to make a big difference. We don't need to, we need to engage with those big groups, but if we can actually do a lot more about raising awareness individually and raising funds individually, then we can start to catch up with the rest of them, so to speak. So, clinical care, let's start with clinical care and go through a few of the issues that arise with patients when they first get diagnosed with a brain tumor. Generally speaking, most patients will either present to their general practitioner or to an emergency department with some sort of symptom, some sort of problem that has arisen which is different to before. And these could be anything from a headache to seizures or weakness of limbs, speech problems, visual problems, confusion, personality change, but also very often incidental findings. And especially for benign tumors, it's not uncommon to find it just as a matter of a routine scan done for something else. And this then sets off this whole cascade of events throughout the hospital system and outside the hospital system that ends up with a whole bunch of people surrounding the patient trying to make sense of it all. And that leaves patients feeling quite out of depth with everything. So we start off with the new symptoms, and as I said, you're usually referred to a neurosurgeon, or the patient themselves comes into emergency with this new symptom, especially if it's something like seizures or severe headaches and drowsiness, those sorts of almost life-threatening conditions that bring you into emergency department. Once we've then stabilized the symptoms, we then move into the investigation phase, and a whole bunch of investigations are carried out, and we discuss what we think our potential diagnoses are all about. Next comes some sort of surgery. Now that could be a biopsy, it could be radical surgery, it could be something in between, and it depends very much on the patient and the type of tumor that we're dealing with as to what is offered there. Obviously, after surgery is post-operative care, followed by histopathological diagnosis. So the tissue is sent away to the pathologist who analyze it under a microscope in various forms and come up with the final diagnosis for us. We then go on to referrals to other specialists and then perhaps to other treatments if required. Now, obviously, if you've got a benign tumor, it's a bit, we do bypass a few of these things. So once the confirmation of diagnosis has occurred, often there is no need for radiation or chemo. Some benign tumors do. However, the vast majority don't, and therefore you might just go from surgery after recovery into follow-up. The key factor, of course, through all of this is communication. And time and again with all of my patients, that's what I get from them, is that they feel lost if people are not talking to them appropriately and giving them the information that they need appropriately. We need to, as doctors, we need to use language that everyone can understand, not medical jargon, which throws a lot of confusion into everyone's minds. So just to go over those stages in a little bit more detail then, stabilisation of symptoms. The first thing that of most patients who have a large brain tumour causing swelling in the brain, you get put on a drug called dexamethasone. Dexamethasone is a steroid tablet, and it is very good at reducing swelling in the brain. So this is a scan of someone with a brain tumour. That's the tumour itself, and all this white stuff around it is swelling in the brain as a result of the tumour. Usually malignant tumours produce this. Some large benign tumours will produce it as well, but the smaller benign tumours, we wouldn't get swelling in the brain. Dexamethasone is extremely good at reducing this swelling and therefore improving symptoms such as headache or even limb weakness, confusion. All of those things can actually reverse quite well with dexamethasone. However, dexamethasone is not without its problems. As I said, it's a very strong steroid agent. We all produce steroids in our body. It's called cortisol, and it's a necessary part of our normal function. However, dexamethasone is an extremely potent form of cortisol, and therefore it produces side effects as well. And the side effects in the short term tend to be it increases your appetite, it makes people feel quite restless and agitated, sleeplessness is very much a part of it, and often even delirium or acute confusion can come into play as well. In the long term, and some patients do stay on dexamethasone for weeks and months during the course of their treatment, and this can give rise to a whole bunch of long-term side effects, including weight gain, which is usually seen in the face, trunk, and back of the neck. There's muscle atrophy, or big muscles thin out and become weaker, and this usually affects the upper arms and the upper legs. Your skin becomes thin and fragile and easily bruised. There's decreased immune system in general, osteoporosis, diabetes. So there's a whole bunch of problems that can arise from long-term dexamethasone. However, it is important to stay on the dex for some patients undergoing treatment in form of radiation and chemotherapy. The other drug that might be commonly used at the start of the diagnosis are anticonvulsants, because a lot of patients will actually present with seizures, and therefore they are placed quite quickly on anti-seizure medication. And there are a whole host of these drugs available. The traditional drug has always been phenytoin or Dilantin, and that's because Dilantin comes in an intravenous form, and if a person has had a first-time generalized seizure, they're usually unconscious and they're in the emergency department. The quickest way to get an anticonvulsant into them would be in the intravenous format. You can't give them tablets at that point. However, Dilantin does have a lot of side effects that are not tolerated well, and thankfully now we have newer agents that are much better tolerated. The side effects of a lot of anticonvulsants include lethargy, dizziness, unsteadiness, headache, nausea, insomnia, but also rashes and liver toxicity. And especially if we see rashes and liver toxicity, you really must come off that drug and try another drug. There's been some contention about whether we should start all brain tumor patients on prophylactic anticonvulsants, whether they've had a seizure or not. Do you need to be on anticonvulsants to prevent them? The consensus now is that there is no evidence that it helps, and therefore we don't routinely start patients on prophylactic anticonvulsants. So, just to take you through a few pictures in terms of investigations. Now, I won't go through blood tests and things. It's a little bit irrelevant at this for brain cancer because there aren't any blood markers as such generally for the vast majority of brain tumors that we encounter. There are some rare ones that we do look at blood profile for. So generally, in the emergency department or in your GP's practice, a patient will get a CT scan as their first line investigation to try and figure out what's going on. A CT is pretty good at telling us, yep, there's something wrong there, but it doesn't give us a lot more information than that. The next step will be an MRI, and this can be done either depending on whether you're an inpatient or an outpatient. There are various places where MRIs can be done. But an MRI gives us extremely good clarity of the anatomy of the brain, but also gives us a lot of information about the tumor itself that allows us to make a diagnosis or a probable diagnosis even without surgery. So certain tumors like, say, meningiomas or acoustic neuromas, the benign entities, they have very, very classic appearances on MRI, which is almost 100% correct. So we can predict those things based on MRI. PET scan is something that is utilized from time to time in various situations. It's not an absolute, but a PET scan is a scan that is useful for looking at the activity of cells or tissues rather than structure. So you can see that it's all a bunch of colors. We can't really make out anatomy from this, but it does tell us if a particular tumor is hyperactive or whether it's reduced in its activity. And that gives us an idea of whether we're dealing with something benign or something aggressive and malignant. We also use this, we also pretty often use PET scans during the course of treatment of a malignant brain tumor to determine if we're dealing with treatment-related changes in the brain or true tumor progression in the brain. Apart from all of these, some centers, and certainly I'm a fan of this, I will use imaging in the form of functional MRI. And that's useful when you have tumors that are close to or that involve important parts of the brain, like the motor area that controls movement or speech areas that control speech. And you want to see the relationship between the tumor and where this function lies. So we do have functional MRI now, which gives us that information, and also diffusion tensor imaging, which gives us an image of where the what are called white matter tracts are in relation to the tumor. And this all helps with surgery and trying to establish whether a complete resection of a particular tumor can be performed safely or not. And some centers use this sort of technology a lot and others don't. So moving on from investigation, so usually once we've got some idea of what we're dealing with, at that point you will have a discussion with your neurosurgeon about what the next step is, and that's usually surgery of some sorts. However, I do want to caution you that there are some small benign tumors where a surgeon might say, don't operate on it, we'll just watch it for a while, and that's absolutely reasonable for some tumors. So most often when we talk about surgery, obviously I'm talking about more, larger benign tumors or intrinsic primary brain tumors like gliomas. So this has always been a little bit of a controversial thing, especially in terms of gliomas. However, as the decades have gone by and surgical technology has improved and our surgical outcomes have improved, the general consensus worldwide now is that whenever it is safe, we would offer maximal surgery. And I've used that word maximal because it means a whole bunch of things. So for some tumors, the safe surgery is a biopsy. For some tumors, safe surgery might be partial resection. And for other tumors, safe surgery is complete resection. And it absolutely has to be tailored to the scan and the patient as to what surgical aim is at hand. So benign tumors, generally, a complete curative resection is possible. However, the location is always the key. So there are some benign tumors that are tangled up around very important nerves and very important blood vessels at the base of the skull. And sometimes you can't achieve a complete resection of these tumors without damaging those structures. Damage to those structures obviously leaves you with devastating problems, which takes away quality of life. And therefore, you might be advised not to have a complete resection in order to preserve quality of life and function. So even with benign tumors, complete resection is not always possible. Metastatic tumors, or tumors that come from elsewhere, the ones that spread from other cancers like breast or melanoma or lung, they usually have a very definite plane around them. So there's a definite margin between the tumor and the brain, and therefore a complete resection is very often possible. Again, if it is in a deep-seated location where surgery is likely to cause problems, we may not recommend surgery. However, generally speaking, a complete resection of a metastatic tumor is possible in the brain. But I just want to clarify that again by saying that metastatic tumors are cancer that has spread to the brain, and therefore it is not just about the brain. It's almost always about where the cancer has arisen and what it's doing in the rest of the body as to whether it can be cured or not. And then we have gliomas. So gliomas are, the vast majority of talks today will be all about gliomas. And gliomas, again, whenever possible, we try to do what's called a gross total resection. A gross total resection or radical resection or maximal resection is all about resecting the tumor that looks abnormal on a scan. We know that that is not the extent of the complete tumor. We know that there are microscopic tentacles that spread away from the tumor that cannot be seen on a scan and cannot be seen under an operating microscope. And we can't resect those tentacles without resecting a whole bunch of normal brain along with it. And that gives rise to a lot of problems. So at this point in time, the maximal resection that we can achieve has to be limited to what we see on a scan as being abnormal. So whenever possible, that's what is attempted. However, again, depending on the location and what structures in the brain are involved, you might be recommended a subtotal resection or even just a biopsy, because in certain locations, even a subtotal resection can result in devastating consequences. So this is just a handful of pictures just to illustrate these different types of tumors. This is a meningioma, very homogeneously enhancing, definite border. You can see brain is normal, tumor takes up contrast very uniformly. All of those things imply a benign tumor. There's no swelling in the brain whatsoever. That's a benign meningioma. This, on the other hand, ugly looking thing. Irregular enhancement. It's inside the brain itself, involves the left frontal lobe. It's causing a lot of pressure. The midline structures are have been shifted across the other side. All of this darker gray area around it is swelling in the brain. That implies something aggressive and malignant. This is probably a low-grade glioma, but you can see how there's no distinct boundary there. It sort of starts here in this hazy area, goes across to the other side, goes across the structure called the corpus callosum. So it's even though it is considered a low-grade tumor and therefore theoretically slow growing, you can see how it's virtually impossible to remove this thing because it's so vague and so diffuse. This thing here is a benign tumor, but it's in a very, very difficult location. It involves a pituitary gland, goes up into what's called the third ventricle, presses up against the brainstem. There are a whole bunch of nerves here, including the optic nerves that detect vision. This is a craniopharyngioma. Again, theoretically a benign tumor, but the location makes it difficult to remove completely. This is a pituitary tumor, again benign, takes up contrast very homogeneously. You can see that the brain's not all that disturbed by it. There's no swelling, there's no pressure. And these sorts of tumors can be resected completely and done through an endoscopic approach through the nose. This is a metastatic tumor. This is a melanoma that's spread to the brain. So there's the tumor. This is actually a bit of a blood clot associated with the melanoma. Swelling around it, again, implies an aggressive process, but there's a definite margin because it is a metastatic tumor that has come from somewhere else. Am I going for time all right, Sue? Great. So with surgery, I'm not going to go on too much about surgery. However, there are many techniques that we use to resect tumors. With benign tumors, we can be a bit more predictive about the type of surgery that is used. However, with gliomas, that's really where we have different techniques and different philosophies about how we like to take out these tumors. And every surgeon will have their own opinion about things and their own technique that they're comfortable with. And there's no way of saying that one is better than the other. There are some techniques that seem a little bit more superior at getting out maximal resection. However, in general, it's what your surgeon is comfortable with doing is what you're best going with. And you can't really criticize one against the other. So the standard is what's called craniotomy with frameless stereotactic navigation. So we use a computer navigation system to target the tumor and to enable us to resect it as best as possible and avoid structures as best as possible. Stereotactic navigation has been around since about 1995, so the technology is not new anymore. And just about every center in Australia and worldwide in the advanced world, in the first world, have stereotactic navigation systems. So it's not a rare entity by any means. The other types of surgery, now endoscopic resections are useful for things that can be accessed through the nose. So things like pituitary tumors, even that craniopharyngioma that I showed you before, skull base, certain skull base or sinus cancers that invade the brain, those sorts of things can be done via endoscopic resection. So using a telescope with a camera up through the nose. Intraoperative MRI, this is my baby, this is what I use. So intraoperative MRI is probably the forefront in medical technology or surgical technology at the moment. It incorporates an MRI scanner with the operating room, in the operating theatre, so that you can maximize resection of a glioma in particular. So intraoperative MRI is the most important indication for use of this is a glioma, not anything else. Pituitary tumors are also best done in intraoperative MRI, but generally it's a glioma surgical tool. With high-grade gliomas, there is also this compound now called 5-ALA, which makes the tumor cells glow pink, and therefore you can see them better, and therefore achieve a greater resection. And a lot of centers in Australia are now able to do that sort of surgery with 5-ALA. And then there's awake surgery. So again, with certain gliomas in certain locations where you're worried about function, Some patients might be offered an awake operation in order to preserve function. One of the other things that you can do instead of an awake is to try and use those functional images that I showed you before, incorporated with IMRI to try and do it with the patient asleep. But those are all contentious issues. At the end of the day, there are multiple ways of taking out a tumor, and they're all fairly equivalent. Post-operatively, hospital stay, usually if it's uncomplicated, most patients are in hospital for around 2 to 7 days. And in this time frame, what happens is that you get up and around, your mobility improves every day after surgery. We want to see that you're attending to all of your personal care, that you're weaning off pain medication, dexamethasone effectively, ensuring that any pain that there is adequately managed and controlled, and then also looking at discharge planning. Now, most people with benign tumors, again, you'll be fine within a few days and you'll be ready to go home and restart normal life. Glioma patients and patients with malignancies, there's a lot more to come. And therefore, all of those things have to be set in place before discharge. So remember, the tissue's been sent off to the pathologist, and ideally a neuropathologist who is specialized in this field. And what they do is that they stain the tissue, but they also use, this is just a standard staining system, but there are lots of other stains that are used to try to come up with the answer of what this tissue is, what this tumor is. This slide here shows a meningioma. You can see how everything's sort of pretty almost, it's all orderly, and the cells seem to form these lovely little swirly patterns. And that's what happens in benign tumors. Everything looks nice. Benign tumors behave well. This, on the other hand, looks ugly and messy. And that's a malignant tumor. All of the cells look different from each other. There's no two cells that are the same. And that's very characteristic of a malignant tumor. Once the name of the tumor has been given, we can then have a discussion about what the future holds. And this is really the key discussion. And this discussion might happen in hospital while you're still recovering, or it might happen in the office of the neurosurgeon or neuro-oncologist, usually neurosurgeon. So at this point, generally, if you have a malignant process, you will be referred on for 2 further treatments. That is radiotherapy. Sorry about the typo spelling. Radiotherapy and also chemotherapy. So radiotherapy is given by radiation oncologists and chemotherapy by medical oncologists. So I've only covered it very, very briefly because there's obviously you can talk forever just about radiation. But radiotherapy these days for gliomas in particular are given in fractions, which are small doses, and that is to allow the brain to recover between doses so that you minimize the damage to surrounding brain. Overall, there's about a 6-week course of treatment. Side effects in the short term include hair loss, fatigue tends to be the biggest problem, headache, nausea, and so on. And during this time, usually patients will have some dexamethasone on board to compound some of these symptoms. In the long term, we do see the evolution of problems such as short-term memory loss, cognitive decline, sometimes unsteadiness of gait, and also during the course of treatment and afterwards, we do sometimes encounter this entity called radiation necrosis, where the radiation's actually worked really well, but it forms a dead lump of tissue. And that dead lump of tissue almost mimics tumor and generates a lot of swelling in the brain, and it can be problematic to manage. And often in that case, we use high doses of dexamethasone to try and reduce the swelling and reduce that dead lump, but also sometimes surgery to remove those lumps of dead tissue. So that's radiotherapy in a nutshell. Chemotherapy, at the present time, The standard chemotherapy that is used for glioblastoma is temozolomide. Temozolomide is what's called an alkylating agent. What it does essentially is that it impairs the DNA repair enzymes. And I'll talk a little bit further when we come to the research part about DNA repair and why that's important in cancer. So it stops DNA from being repaired and therefore doesn't allow cells to replicate. And that's how it works. However, most malignant cells will find a way around temozolomide to then progress despite it. It is a tablet. It's given in conjunction with radiation for that 6 weeks, and then generally given as 6 cycles of adjuvant therapy afterwards. Overall, it's fairly well tolerated with minimal side effects. However, one of the things that we do find with glioblastoma during the treatment of with temozolomide is this entity called pseudoprogression, which can throw a lot of confusion into scans when we don't know whether it's progression or whether it's a treatment effect. Benign tumors, just to cover it quickly, generally speaking, if a total resection has been achieved, then you're essentially cured of this problem, and you might be advised to have some ongoing follow-up scans, especially if you're a young person, and there might be some likelihood of it coming back. However, generally, if it has been resected completely, it should not come back. Some benign tumors, however, do have a propensity to recur, like those craniopharyngiomas, for instance, that I showed you. Location, as I've mentioned before, is the key as to whether you can resect completely or not. If there is a residual bit of tumor, then the options are to watch and wait, so just to see what happens. Benign tumors are slow growing in the fact that they grow like 1 millimeter or so a year. So they're very, very slow growing. There's no need to rush in with operations at any stage. And the watch and wait approach is very routinely used. Sometimes, however, we might advise radiotherapy or a form of focused radiation called stereotactic radiosurgery. A little bit more on benign tumors. Some benign tumors can actually be treated purely with stereotactic radiosurgery without any open surgery being required. And the classic one would be something called an acoustic neuroma. If it's been found at a small size, we might advise just stereotactic radiosurgery because it is extremely good at controlling these tumors for decades. Others can, as I said earlier, if they've been picked up incidentally and we find a small tumor which is doing absolutely nothing, causing no symptoms whatsoever, and we can be very definitive on a scan that we're dealing with a benign lesion, we might suggest no surgery, just watch with regular scans. Some benign tumors, however, especially certain skull-based meningiomas that just sort of take up the entire skull base, we really have to look at them as a chronic disease. It is something that needs to be managed from time to time over the years. They're generally not life-threatening if they're a good grade meningioma. However, it can be a problematic management course that can take years. So, after all of this is what happens. You're in the middle with all of these people around you. And all of these people will be giving you different opinions about their specialty and about someone else's specialty. And that throws about a lot of confusion. Some people actually like that there are all these people around to go to, and I think that it's useful, it's absolutely imperative that we have these specialties that we can refer to for expert care and advice. Some patients, unfortunately, who are in a remote location, for instance, they really do feel the lack of these people around them to give them guidance. So who's the go-to person? That's the big question. And I think that's what a lot of glioma patients feel, and that's why they feel out of depth. Where do you go? Who do you talk to get answers? And I think in every patient's case, it has to be individualized. Certainly in my practice, I like to be the go-to person, but I know that in other neurosurgeons' practice, they will defer to oncologists or GPs or neurologists even to be the go-to person. And a lot of neurosurgeons will see themselves as purely technicians doing the operation, but leaving the rest of the care to others. So it really, everyone's a bit different. But you have to, as a patient, you have to identify who that person is. Ideally, we need these people, clinical care managers, case managers, nurses, who can coordinate all of us so that you, as a patient, you feel like there's always someone to go to and that someone always knows who to refer you to. So the ideal setup, in my opinion, for appropriate, good clinical care of a glioma patient or a brain tumor patient is that we need to have optimal centers of care. So we need surgical expertise and specialization. These are the facilities or the points that we need at these specialist centers. So we need the surgical expertise and specialization. We need surgical technology available. We need dedicated specialists in radiation oncology, medical oncology, neuroradiology, neuropathology, regular multidisciplinary team meetings. This is integral to good quality brain tumor care. Actually, it's integral to most cancer care. We need strong supportive staff, case management, coordination of care. We need access to trials through these centers, both local and international. And we need on-site tissue banking and research facilities with data collection. So ideally, in the perfect world, your brain cancer hospital should have all of this. And if we have all of this, then patients who come to that center will feel fairly secure that they're being looked after well and that they're getting the best care available and that they're getting the information that they need. The current situation, however, is far from that. So I've just done a little bit of number crunching, and in Sydney, there are about 20 hospitals that do brain surgery in some form or other. There are about 520 gliomas that are diagnosed in New South Wales every year. This translates to about 26 gliomas a year per hospital. And that's if it's an even spread, but it's not an even spread. Thankfully, there are some hospitals in Sydney that attract the vast majority of brain tumor patients. However, that does mean that there are some hospitals out there that might only see 1 or 2 patients with gliomas a year. And that's not good for anyone. This is what causes the incredible fragmentation and the dilution of expertise and care. And the dilution and the fragmentation is not good for anybody. So it doesn't allow surgeons to develop skills and knowledge. We have difficulty setting up tissue banks and research labs. We have difficulty recruiting patients into trials because of this. Funding bodies can't truly identify where to infuse funds, and we have difficulty attracting allied health professionals who want to specialize in this field. So in my opinion, the biggest thing that has to happen is that we need to have specialized centers that deal purely with brain cancer. The lack of cohesive care and for patients and families that result out of this makes patients and their families feel out of depth and unsupported. And this is mostly true for patients who are in rural areas and sadly in small states in Australia as well. Moving on from that, I just want to cover, how am I going for time? All right. Just want to go over research. Now, this is something that I'm just sort of getting into, and I guess I'm going to give you research from a layperson's perspective. So, George Gershwin, he's probably the most famous person in modern era who died from glioblastoma. So he died at the age of 39 from a glioblastoma multiforme back in 1937. He's a jazz musician, composed Rhapsody in Blue, if anyone knows. brilliant man. Back then, they didn't even have any way of diagnosing the condition. There were no scans available. There was no CT. There was no MRI. There was no anything. He was thought to be delirious and mad. He kept complaining of weakness of his limbs. He was complaining of smelling burning rubber. He would get dizzy, have fits. All of those things that were very classical for brain tumors, but they had no way of even diagnosing it. However, right at the end of his disease, someone said, "Oh, you probably have a brain tumor." But it was too late. And there were some surgeons around the time, Harvey Cushing, who was asked to operate on him. However, it was way too late for George, and he ended up dying at the age of 39. So, just going back a little bit with history, for many decades, there was very little research and development in the treatment of GBM. The first real change probably came with Temozolomide in around the late 1990s. It was discovered or created by this man in Birmingham in the UK. Well, he was one of a team of people. And I think this is a good statement. There are lots of things in medicine where there isn't just one moment when it comes into existence. It actually takes years to develop something. And even with the future, it will take years for us to develop things to a better place. And that's true not just in medicine, it's true for everything in life. However, he does state that it was funding from Cancer Research UK that made it possible. And of course, we all know that. We all know that it is funding that makes research possible, and without the funding, we can't progress. So after finally, once it did come into existence, the drug was first authorized for recurrent glioblastoma in about 2001. It is now used as first-line treatment. 2005 was when Stoop et al. Showed that there was a distinct benefit for giving temozolomide with radiation rather than in succession. And their original paper in 2005 showed a 2-year survival rate of 26.5%. Now that is actually higher today, but I think that was the first time the neuro-oncology world was actually able to speak about years of survival in glioblastoma. So it was a big step. It's not huge, but it was the first time we could talk about it. So all of the above was really achieved in what I would say is the pre-genetic era. Just before we go on to genetic stuff, I want to talk about the cell cycle very quickly. This is where it all happens. So every cell in our body replicates. Some cells don't replicate at all, like neurons, but pretty much every other cell has to divide, replicate, they die, they get replenished. That's the nature of human cells. Skin cells, for instance, undergo that cycle every day, constantly. Other cells undergo that cycle over months, and other cells don't replicate at all. Some cells are sitting in this rest phase when they're not replicating. But throughout this cycle, there's a whole heap of dynamic things happening in that cell. There's DNA that has to be duplicated before a cell divides. And then every bit of that DNA codes for simple functions within the cell, which then gives rise to functions of an organ, functions of who we are and how we look. So it's all about this. And usually a tumor arises because there's uncontrolled growth of cells. And this is usually due to some genetic flaw that has happened that has given rise to this uncontrolled, unregulated growth. The genetic functions in tumors do many things. They can stimulate cell division, they suppress cell divisions, they promote cell death. They also promote cell migration, or how cells move from one area to another. What causes these mutations is what's unknown at present. We know that some people have inherited factors that have been passed on through generations that might make them more at risk of developing tumors and cancers. We know that environmental factors play a big role in certain cancers like lung or melanoma. So we are now entering this era, the era of genetic stuff and targeted therapies. And this is all about, so all of this really started back in 1956 when Watson and Crick first described DNA. DNA is that entity that codes, as I said, for every little function in a cell and then as who we are. The Human Genome Project started in 1995 and was completed in 2003. So in 2003, we had a map of the entire human genome. This took years, obviously, as you can see, but it also took many international labs working together to make it happen.